Morning, everyone, and welcome to Section of Cardiology Grand Rounds. I am really honored to introduce our speaker today. Dr. Naveen Pereira is a cardiologist from the Mayo Clinic, where he practices advanced heart failure and transplantation and runs the dilated and genetic cardiomyopathy clinic there. Dr. Pereira has earned numerous titles. He's professor of medicine with the Department of Cardiovascular Diseases, Associate Professor of Pharmacology, the Department of Molecular Pharmacology and Experimental Therapeutics, and Chair of Clinical Trials Operations and Medical Director of Clinical Trials, Mayo Clinic. I just want to give some context for the impact that he's had with over 150 publications. So, 1 in 250 people have a dilated cardiomyopathy. About 30% of them have a genetic cardiomyopathy, and less than 10 to 20% of them have actually been genotyped. And so the work he's done has contributed hugely to our ability to do that and understanding of the information. I would say that, he's really pioneered frontlining genetic testing for dilated cardiomyopathies at the Mayo Clinic. He has a basic science program where he describes common genetic variation by performing resequencing studies and then determining the significance of those on a cellular level as well as a population level, and then has pioneered innovative techniques. And so one example is, developing an AI algorithm to detect cardiomyopathy based on 12-lead ECGs, which has huge significance. And then I think has been a great support to the community. I can say personally, he's always been available to discuss challenging or rare cases, and I've always been struck by how generous you are with your time and thoughtful with your advice. So in many ways, I look up to you as a clinician and person. So thank you, Dr. Pereira. We look forward to your talk.
Thank you so much, Omid, and Dr. Howard. Thanks for having me here. It's really a privilege. I've never been to Calgary and stayed in Calgary, and it's a beautiful town. The medical center, the undergraduate facilities, the medical school is amazing, very impressive. And I'm really impressed, having had dinner with the group yesterday, as to the direction that you're heading. It's very exciting times, and I'm glad to have visited you all. So, Omid, thank you very much for the introduction. I have passion for this field. I hope it comes across, and I hope it inspires you all. It's interesting that I've spent time in the laboratory doing basic science work, done population work, I've done clinical trials. So I have some idea of the spectrum of clinical research, and I hope I convey some of that to you today. So really, what I like to do today is describe the genetics and of dilated cardiomyopathy, and describe its importance in screening family members, prognosis of the disease, and therapy, how it's impacting all three: diagnosis, prognosis, treatment. We started a dilated cardiomyopathy genetics clinic. There is a hypertrophic cardiomyopathy clinic too, and there's a channelopathy clinic. So all of those are genetic-based and therapeutic-based. And so the dilated cardiomyopathy genetics clinic is new relatively in our workflow, and I'll show you some cases to see if we are making a difference. And then I want to show you how there's some really striking diagnostic dilemmas in heart failure, if you look for them, and how you can use genetics to help solve those diagnostic dilemmas. And then finally, we go more towards the research front as to how actually you can use genetics, which is in a very agnostic way, and identify new pathophysiology of cardiomyopathy. And also exploit the variation in therapy that we see in with heart failure treatment, and then exploit that to find new pathways and potential for new therapy. And you'll understand as we move forward what I'm talking about. So here's dilated cardiomyopathy. Decades ago, we classified it as idiopathic. We would tell the patient, I don't know. You have no other cause for a low ejection fraction. And so we called it idiopathic. And this was primarily family history based. And 5% of families, 5% of patients had a familial history. So this classification kind of got revised. There was a Mayo Clinic study that was published actually in a New England Journal in 1992. And they said, let's not rely on family history alone. Let's do echoes on all family members of patients with dilated cardiomyopathy and see if family members have dilated cardiomyopathy or abnormal left ventricles. And look at that. I mean, there was a fourfold increase. So what this very simply shows that family history is very important, but family history does not diagnose familial dilated cardiomyopathy. You really have to screen patients by echocardiography. And then subsequent studies published more recently show kind of ballpark, depending on whether you use reduced ejection fraction or just abnormal left ventricular dilation, it can be up to 30% of family members of your patient with dilated cardiomyopathy can be affected. This is really important and it's meaningful to me. I've had patients whose family members have not been screened, family members have died suddenly or presented with catastrophic new onset heart failure. And we all know that these family members can be picked up early and treated. So it highlights what Omid was saying. It's so important to use not only cardiac surveillance with echocardiography, but genetics to pick up these patients. So here's, in general, the most common genes that cause dilated cardiomyopathy, and I don't want you to remember all of them, but really, there are these sarcomeric genes. There are genes that enable the structural integrity of cardiomyocytes and enable communication between cardiomyocytes like desmosomes or desmoplakin. And there are genes that are involved in transcription within the cardiomyocyte, like RBM20, that actually mediates transcription of chitin. The genes that encode the lamellar membrane of the nucleus. So there's lamin AC, there are mitochondrial genes. So there are some channelopathy genes. So there are multiple genes involved in the pathogenesis of genetic cardiomyopathy. In general, when you do genetic testing, the yield of genetic testing is 10 to 40%. Okay, so there's variability. And this variability is explained in part by the development of the Madrid genotype score. So if you have a family history of dilated cardiomyopathy, the yield can be up to 40%. If you have all these variables, low ECG voltage, presence of skeletal myopathy, absence of hypertension, absence of left bundle branch block, and you've probably seen this in your practice. I see it. If someone has a left bundle branch block, it's very unlikely actually to see a positive genetic test. And so they've shown very elegantly, and this was validated, that if you have at least 4 of these variables, the yield is very high. So there is a way of refining based on clinical variables as to who is going to have a positive genetic test. And it's also very important that the genes that cause dilated cardiomyopathy can also cause non-compaction, restrictive cardiomyopathy, hypertrophic cardiomyopathy, and arrhythmogenic cardiomyopathy. So there's a big overlap of these genes. And so initially we were very focused and said, let's just do DCM genes, let's just do HCM genes. But now we do what is known as a pan-cardiomyopathy panel, which roughly involves 81, 82 genes. And it's the reason we do that is we understand there's a genetic overlap for all these conditions. And so as we've gone bigger, have we got better is the question. And so what we see is as the number of genes that are sequenced are more, the number of negative tests come down, the number of positive tests go up, but the number of what we call as variants of uncertain significance go up significantly. And so these variants of uncertain significance are still a diagnostic dilemma for us. and people are trying to develop high throughput assays to sort these variants of uncertain significance. One of my cardiology fellows is using newer AI-based protein modeling and protein structure prediction tools to try and assess variants of uncertain significance, whether they actually have a deleterious effect on protein structure and function to determine pathogenicity. And you can see the most common gene that is involved in dilated cardiomyopathy is titin. And I think that's a good, when we do genetic testing, titin turns out to be the most common. Does having a genetic cardiomyopathy alter prognosis? And the answer from multiple studies is yes. So if you are gene positive, you're more likely ultimately to need heart transplant or an LVAD. And it's interesting, I mean, we do see this initially, all patients, whether genetic or non-genetic cardiomyopathy patients, improve, but you see the divergence later. There's almost a breakout. I've got multiple patients that demonstrate exactly this. So ultimately, patients fail guideline-directed medical therapy, they're more likely to have a genetic cardiomyopathy. What about the first-degree relatives? So if a proband, if a patient's identified with dilated cardiomyopathy, you do genetic testing for the family members, right? So what happens to them? So this was a very nice natural history study. So if they are genotype negative, meaning they do not have the gene that their family member has, the chances over a 5-year median follow-up period of them developing cardiomyopathy is 0 in this particular study. But if they are gene positive, there's a very high degree of penetrance. And that's one of the reasons you should do genetic testing in family members, especially, I mean, you only do it when the proband is gene positive, obviously. And so you can assure them that they have a good prognosis if they're gene negative, but if they're gene positive, that there's a high penetrance, you pick it up early, you can treat these patients early. Does it alter treatment ultimately? And you can see here, and this is one of the problems I have with ICD studies. There's a big study now being done, randomized clinical trial, whether ICDs should be put into patients with non-ischemic cardiomyopathy, but there isn't a genetic testing stratification in that clinical trial. And you can see there are many natural history studies now of patients who have LMNA mutation. They have very, very high risk for developing ventricular arrhythmias. And in fact, if you look at their risk factors, you can have just non-sustained VT and be male sex, and that may justify not ejection fraction. Remember, for ICDs, we use a 35%, less than 35% ejection fraction after treatment as criteria for putting ICDs. But for LMNA mutations, it's class 2 because there are no clinical trials. It's relatively rare. You can't do one. But if you have just non-sustained VT in male sex or certain types of variants, and the EF cutoff is 45%, not 35%. So low threshold for putting an ICD based on a genetic mutation. Similarly, we recognize that filament C and patients with phospholamban mutations, you do not need to use a cutoff of 35%. You can justify an ICD with a cutoff of less than 45%. There are benefits because now, as we identify these patients with genetic testing, you can offer them gene therapy. So there's PKP2, which is predominantly an arrhythmogenic cardiomyopathy. There's a phase 1/2 multi-center gene therapy trial. There's Friedreich's ataxia, which is primarily a skeletal myopathy. Patients have mitochondrial issues, but they die predominantly from dilated cardiomyopathy or hypertrophic cardiomyopathy. So there's gene therapy for that, and there's BAC3 dilated cardiomyopathy, very poor prognosis. So there's gene therapy being planned for that. So if you don't do genetic testing, you don't identify what your patient has, then how are you going to offer them innovative clinical treatments like ICDs very early on in their course for high-risk patients, or even innovative gene therapy. So the ACCHA guidelines say that, oh yeah, it's class 1. So if your patient has a gene that's positive, then family members have to get genetic testing. It's class 1. But my question here is, how do you know whether your patient is gene positive? You have to do genetic testing in them in the first place. They give that a class 2, okay? Because it's very randomized clinical trial based, and these guidelines, and it's just very hard to do trials in these type of scenarios. So the ESC guidelines were a little liberal, and they said all patients with diagnosis of dilated cardiomyopathy, hypokinetic non-dilated cardiomyopathy, and all first-degree relatives should have genetic testing. So we developed a genetic testing program, and we realized even at Mayo, a lot of patients were not getting, eligible patients were not getting genetic testing. And so what we did was, it's embedded within the heart failure clinic. The primary drivers that enable genetic testing are the heart failure nurses, actually. And so patients are given a form, they fill out a family medical history, so it's not as beautiful and perfect as genetic counselors. Then they are shown a video where the genetic counselors do genetic counseling by video, because it's a generic genetic counseling session. And the nurses have a frequently asked questions answer sheet where any questions that the patients have basically answered. And importantly, at least in the US, insurance pre-authorization is obtained by the genetic testing company. And then the results that come back go to a cardiologist who has expertise in genomics. So the importance and really benefit of this process is when the patient comes to see, say, Omid can order genetic testing in the heart failure clinic, and it can be done at the same time. And he doesn't need to then order a genetic counselor visit or medical genetics. The patient may or may not come back. In the US, we find a lot of these patients don't want to come back for genetic testing. So it can be all done at the time of the clinical encounter. So did it make a difference? So we published this 2 years ago, and genetic testing increased from 15% to 34%. Genetic counseling increased from 15 to 34%, and testing almost doubled. So still low, but doubled. And the reason these numbers are not as impressive is because we targeted just the new heart failure patients and not the existing patients. And we, in the study, looked at all eligible DCM patients, whether new or established. But just making the process easy and seamless within the clinical workflow enables an improvement in genetic testing. So are we making a difference? So here's a case, 24-year-old female, during exertion at cardiac arrest, was apparently in pulseless electrical activity, underwent CPR. She was in refractory shock, was on industrial doses of inotropes. There was no family history of sudden death or cardiomyopathy. Echo initially showed EF 20 to 25%. So she was started on GDMT, weaned off inotropes. Week later, EF improved. So this dramatic improvement in EF, people thought, well, maybe she has myocarditis, which, there's some edema on MRI, presumed myocarditis. She came to be seen in the heart failure clinic. And people generally would have continued GDMT and said, maybe you had myocarditis and this was fine. So we did genetic testing. And she had a pathogenic variant in the rhinotidine receptor. And her diagnosis actually was CPVT, which was confirmed on stress testing. So it actually changed her therapy. She had to get nadolol instead of metoprolol, and a very different course. And since she had primary cardiac arrest, she then warranted, despite a normalization of EF, an ICD. So you see, completely changed her therapy. And so here's another case, 59-year-old female, EF was 45%, became progressively worse with symptoms, EF declined, and someone said, well, is this an inflammatory cause? Got cardiac PET imaging, and it was suggestive of myocarditis or sarcoidosis. MRI showed epicardial inflammation, late gadolinium enhancement. So these were the early days of the sarcoid clinic. And basically, physicians said, well, we should do a biopsy. And if there's inflammation, we'll start immunosuppression, et cetera. And I said, whoa, why don't we do genetic testing? And indeed, she had 2 pathogenic, likely pathogenic variants. And some of these genes can be associated with inflammatory cardiomyopathy. So she didn't have sarcoid or myocarditis. She had basically a genetic cardiomyopathy, and we know genetic cardiomyopathies can be inflammatory. Now, Omid is trying to answer the question whether inflammatory genetic cardiomyopathies course can be attenuated with immunosuppression. We don't know. But what I'm saying here is importance is, well, first diagnose the patient. Is it a genetic inflammatory cardiomyopathy? Don't think that the patient has sarcoid or myocarditis. So you have to do genetic testing first. And in fact, we looked at all our patients coming to sarcoid and looked at genetic testing, and 20% of patients who are presumed to have sarcoid had actually genetic cardiomyopathies. So 1 in 5, right? It's a very different disease than what you think about when you think about sarcoid. And so it's, I think, imperative, like if you suspect someone has an inflammatory cardiomyopathy, to do genetic testing. And can we use genetics to solve some really difficult, interesting cases? So here's a female who presented at age 32. She had abnormal LFTs, enlarged liver. 2 years later, she had palpitations, she had mild LVH-PACs. 6 years later, she came with a stroke, and she was diagnosed with hypertrophic cardiomyopathy. Ultrasound 2 years later of a liver, because she was having some abdominal pain, showed she had underwent cholecystectomy, and they did a biopsy because she had abnormal LFTs, and they thought there's some glycogen storage disease in her liver, okay? So they sent her to Mayo, and here's the echo. As you can see, very thick left ventricle, thick right ventricle, and just looked like hypertrophic cardiomyopathy. Our echocardiographers thought this was probably some type of storage disease, and so she underwent biopsy. And my colleague, Jeff Geske, pushed for that. And this is electron microscopy that shows myelinoid bodies within the cardiomyocyte. So this is very real, right? So he was right. It was some type of storage disease. This is the pathology report: storage disease, hydroxychloroquine toxicity, medication result, Fabry, Danon, et cetera, right? What does this patient have? And so we had done genetic testing for glycogen storage diseases, et cetera. Everything was negative, right? So, and we are staring at this and saying, what does this patient have? It's a real abnormality in the heart cell. So the patient actually pushed for getting whole exome sequencing. And here's what the whole exome sequencing showed: a bunch of variants of uncertain significance. But she had a pathogenic variant in the
I did that.
Oh, who's that? A pathogenic variant in the sulfamidase gene. And so actually medical genetics saw her and said, we don't have an explanation for her cardiomyopathy. She's just a carrier for mucopolysaccharidosis type 3A, because you have to be homozygous for a pathogenic variant in this gene to manifest disease. And no one's heard of a 42-year-old female as having mucopolysaccharidosis with no neurological involvement. She had 0 neurological involvement, high-performing, cognitively intact person. But here's a curious cardiologist, and he said, I'm staring at these things in the cardiomyocyte, and I know mucopolysaccharidosis patients can have thickened ventricles if they live long enough. You know, heck with genetics. Maybe she does have mucopolysaccharidosis. So we sent her urine for this glycosamine aminoglycan analysis. And look, what that enzyme does, the sulfamidase enzyme, it breaks down heparan sulfate. So if it's not working, you get a lot of heparan sulfate that accumulates within the cells. Look at this, normal is 0 to 1. She's 100-fold increase of heparan sulfate. So this director of this lab called me, said, I want everything repeated. I don't believe this. And then the enzyme, the sulfamidase enzyme activity, 2.2 is normal. She had homozygote-like reduction in enzyme activity of 0.4. So she basically had a diagnosis biochemically of true mucopolysaccharidosis type 3A. And what led us to this? Why did I think about it? It was whole exome sequencing. And so whole exome sequencing is being done at the Mayo Clinic for very difficult to diagnose what we call Odyssey cases. The positive yield is about 30%, costs about $8,000, but families are intensely gratified because they get a molecular diagnosis of their disease. And like this patient, now knows what she has. And basically, there's select patients who have molecular targets that can be used for treatment. Can we use genetics to understand pathophysiology of cardiomyopathy, right? Do we really know why some patients develop cardiomyopathy and some may not, even if they have a gene positive? So we know that there are epigenetic factors, right? Chemotherapy, myocarditis, peripartum cardiomyopathy. So they may have an underlying monogenic cause like titin, but they have precipitating factors like peripartum cardiomyopathy, inflammation, et cetera. So you may have a genetic substrate, right? And you have precipitating factors like these that cause cardiomyopathy. But what's really interesting is all of us carry common genetic variants that put us at a risk for dilated cardiomyopathy or hypertrophic cardiomyopathy. So unlike the genes that I just showed you, titin, et cetera, those are rare monogenic causes. These are common genetic variants. And these genetic variants also drive how our heart looks, how dilated it becomes, how thick it is, et cetera. I don't know if you knew this, but we all have a certain thing. And so a fellow came from Italy and looked at Olmsted County. And indeed, what we found is these genetic variants associated with LV dimensions and function in Olmsted County, and then was associated with development of dilated cardiomyopathy. So in addition to those epigenetic factors, there's common genetic variation that predisposes us to developing cardiomyopathy. Is that important? Yes, because if you have a lot of these common genetic variants, you're more likely to express disease. So why do some people develop disease and some don't? Maybe it's the scaffolding of this common genetic variation that puts you at a higher risk. So this is a polygenic risk score for HCM. And if you have a higher risk score, more likely to develop disease, right? So a lot of times but what do these common genetic variants do? How do they really predispose you to cardiomyopathy? No one really knows, right? So they show these beautiful statistical genetics studies. And so we said, let's take a look and see if these gene variants are associated with fibrosis in a normal population, right? So there's MESA, 1,255 patients. Joao Lima, Dr. Howard, I don't know if you know him, from Hopkins, collaborated with us. He had done all these CMR. He calculated extracellular volume in these patients, which is probably the most precise MRI measurement for fibrosis, in my opinion. And so we took these SNPs that predispose you to cardiomyopathy and said, is it associated with fibrosis in this population? Okay. And indeed, we found 2 SNPs in a gene called SMARCB1. No one's heard of that in cardiology, okay? And this is the beauty of doing these genetic studies. Highly significant, associated in HCM with increased ECV. Now think about this, an increased thickness of the heart, okay? So here's the variant in a gene that's associated increased ECV with HCM and hypertrophy. That variant, so then you have to ask yourself, what does that variant do to the gene? It decreases expression of the gene. So this is publicly available. So these are the patients who have this minor allele, and there's reduced expression of the gene, okay? So reduced expression of the gene is associated with increased fibrosis, okay? So you'll say, oh, all this is great association. Can you really prove it to me? And that's the beauty of going to the lab. So you go to the lab, and basically you can knock the gene down, so decrease expression of the gene, and voila, you see increased fibrosis, alpha-actinin, collagen, and this is just showing you that decreased expression of SMART-CB1. So we've started with the question that arises from the study is, actually fibrosis may not be reactionary. Does your propensity to develop fibrosis increase the risk of cardiomyopathy? Is it an insidious pro-cardiomyopathy milieu that it creates? And this is not the only study. So there's a study published by Kristen Seidman's group that was published in the New England Journal in 2010. They took blood from patients who are gene positive for hypertrophic cardiomyopathy. So they had the gene, but they did not have hypertrophic cardiomyopathy. And they measured collagen, circulating collagen factors, extremely high compared to control. They had not developed cardiomyopathy yet, but they had a pro-fibrotic milieu. It really raises interesting questions about the pathophysiology of cardiomyopathy and fibrosis. And you'll see it comes up again. So here's cardiomyopathy patients. People have done GWAS. They've identified loci that puts them at increased risk for developing cardiomyopathy. We try to show functional significance of these and show that there's a completely new gene, SMART-CB1, decreased expression of which is associated with increased fibrosis, and confirm that in the laboratory, and then open up a whole pathway of pathophysiology in cardiomyopathy, and raises the question of fibrosis promoting cardiomyopathy. What about treatment response variability? Same dose of metoprolol, right, to two different people based on CYP2D6. Ooh, what happened? Kind of disappeared. They're like, stop now, Pereira. Yeah, she's got it.
Yeah, yeah, we just.
Oh, okay.
There we go.
And
Yeah, I'll try. Oh, can you go directly there? There we go. Well, I guess I got too excited, and so here, this is guys, we treat our patients every day, but this is what happens. There is variability in our patients. So this is CYP2D6. Poor metabolizers really have a high level of metoprolol, and ultra-fast metabolizers have low level of metoprolol. And we see this. Some patients require industrial doses. And this was BEST. It's the only beta blocker that did not improve survival in heart failure patients, bucendolol. But it very elegantly shown that if you have a certain genetic variant in the beta receptor, you're more likely to show response. Again, why I'm showing you here is we can fine-tune treatments based on genetic variation. So what we collaborated with several centers across in Europe and the States, and managed to get recent onset cardiomyopathy patients, difficult cohort to collect because we really wanted to see what their change in ejection fraction is. And this is traditional, by the way, two-drug therapy, ACRB or beta blockers. which raises a whole set of questions about upfront quadruple therapy in people, because this is what we see in our patients. Some patients will completely normalize the EF, some get worse, and some remain the same. Why? Why do you see this variation? I mean, people have looked, okay, females, et cetera, maybe, there's some clinical variables, but what is the molecular mechanism that you see this variation in response? So we did a GWAS, and we found two loci, NAV3 and TMEM158 and CD7. No one's heard about this in cardiology, right? That may be associated with improvement in ejection fraction, okay? Improvement. So we said, what do these genes do? I mean, so what you can do is go to the UK Biobank, plug in the gene of interest, and this is reverse GWAS, it's called PHEWAS. What phenotype is associated with these genes, right? No one's heard of this in cardiology. Does it have any cardiac impact? There are 2,400 phenotypes: pregnancy, appendicitis, tonsillectomy, etc. Guess what showed up? 10 to the power minus 27, death due to heart failure. So the genetic variation, these two genes, was associated with death due to heart failure, okay? Which is exactly what the phenotype was. Remember, change in heart function was the phenotype, okay? So you said, well, this probably means something. Where's these genes express? And we find this high variability, very little in the heart, but a lot of it in fibroblasts. Same thing, high variability in fibroblasts, okay? So, and we know that fibrosis is the most powerful predictor of improvement or lack of improvement in heart function, fibrosis detected by cardiac MRI. And so this is a seminal study published in JAMA, and it was even greater predictor than LVEF, right? So now see where we are heading here? Two genes associate improvement in heart function, expression, variability in fibroblasts, fibrosis, very important for change in heart function with treatment, prognosis. So should we study fibrosis? So I won't go in details, but these are basic science studies basically showing TMEM158 is a pseudogene, very little transcript, no protein expressed in human cardiac fibroblasts. We took that variant, and whenever you have a variant, you ask, what does it do to the gene? And so we took this variant that was associated with improvement in heart function, and we showed decreased expression of CDCP1, okay? CDCP1. So you knock CDCP1 down, knock TMEM down. TMEM does nothing to cell proliferation. So this is cardiac fibroblast proliferation, but significantly reduces cardiac proliferation. So decreased expression of this gene is associated with improvement in heart function. Decreased expression of this gene is associated with reduced cardiac fibroblast proliferation. Now, I'm going to go rapidly through these studies, but the question is, you can take this gene and do RNA sequencing of fibroblasts to discover new pathophysiology, new pathways. Of all the 23,000 genes, when you knock CDCP1, knocking CDCP1 is good, remember? Because it improves heart function and it basically decreases fibroblast proliferation. Guess 10 to the power minus 300. What shows up here? Do you know what this is, Omid? It's ST2. So decreased CDCP1 decreases soluble ST2. What is soluble ST2? One of the most powerful biomarkers that's associated with prognosis in heart failure, just like NT-proBNP. So less ST2, better your prognosis in heart failure. And this is what knocking CDCP1 does. And then we show that, so what we showed with this RNA sequencing studies, that PDGF-beta plays a very important role, and we show CDCP1 expression is driven by PDGF-beta, and it activates AKT, ERK. These are proliferative pathways. And basically, we showed that CDCP1 knockdown decreases proliferation of human cardiac fibroblasts in the presence of PDGF-beta, which is one of the most important and early mediators of fibrosis. And in that, the downstream consequences is also decreases activation of AKT and ERK. So what I really wanted to show you was knocking down CDCP1, you uncover just new pathways, and you show how it can occur downstream molecular signaling. So that was all in vitro. So we said, does knocking down CDCP1 in vivo in a mouse model, so we created a genetic knockout mouse model, does it attenuate fibrosis, right? So can you cause fibrosis in mice? Yeah, you can give them angiotensin to phenylephrine, right? So you gave angiotensin phenylephrine to these mice, and then we took their hearts out and quantified fibrosis. And indeed, angiotensin to phenylephrine increases fibrosis. So y-axis is percentage fibrosis. But look what the knockout mouse model did. It decreased fibrosis compared to the wild type. So what we showed from, and this is just depiction, picoseries staining, you can see the ventricles thick. All this is collagen, and the knockout mouse looks almost like the wild type mouse. Dramatic 35–40% reduction in fibrosis. So we started with change in heart function. What drives that? We showed that decreased CDCP1 is associated with improvement in ejection fraction. We take it to the lab. We show decreases fibroblast proliferation. Then we show that it decreases fibrosis, not only in the lab, but also in the mouse model. And the question is, what does it do to dilated cardiomyopathy? So we are answering that. We have a DCM mouse now. But the question is, what an attractive target for potential drug development. So I worked with Caulfield's lab at Mayo. This is the molecular structure of CDCP1. It has a cleavage site on a bottom side. They identified 147 compounds that bind to these two sites. The cleavage site is really what activates downstream signaling for CDCP1. And we started screening them in a rapid throughput assay for fibroblast proliferation, and we found a compound, we label it as C3, that binds to the cleavage site and markedly reduces human cardiac fibroblast proliferation. So really, this window of leveraging genetics to actually creating therapy is exploding. There are 21 gene-based therapies for heart failure, 18 in cardiomyopathy. There are other gene therapy trials for hypertrophic cardiomyopathy, and you'll all know about CRISPR-Cas9, which is going to a phase 3 clinical trial for amyloidosis. So hereditary cardiomyopathy is common, as Omid said, 1 in 250. Family history is important, but I really think you need to screen patients either by echo and genetic testing, preferably both. Mendelian rare genetic variation, these monogenic causes like Titin, provides a reasonable diagnostic yield up to 40%. Why is it important? You get a molecular diagnosis for your patient. It helps with family screening. Family is gene negative. It's reassuring. If they're gene positive, you need to watch them. It's a prognostic marker, and it's being now targeted in clinical trials for specific treatment. I hope I convinced you that background common genetic variation that we all have can affect our propensity to develop DCM, HCM. And then I showed you how it can help understand novel disease pathophysiology like smart CB1 and fibrosis. Response to heart failure therapy is variable. And I showed you how we can leverage that to identify new genes that are associated with improvement in heart function, and then how you can demonstrate its significance in the lab, in the animal, and then develop drugs. And so really it's the future, and I hope, I mean, there are so many people to thank and multiple collaborators. This work takes a lot of village to accomplish. And I really thank you for your attention. Thank you for having me here.
Thanks so much for that fascinating talk. That was wonderful. So we'll open the floor to questions. We'll start off in the room. Are there questions in the room? Catherine.
Hard for our patients and even the providers. So what basically happens is we partnered with a genetic testing company. And a lot of the payment situation for the patient is dealt with by the company. So the company basically tells the patient that your liability will be up to $200, for example. And if you have to pay more than, we'll work with your insurance company. So the testing company works with the insurance company, gets approval. And if it's going to cost you more than 200, we'll call you and see if you want to proceed. So nearly all my patients with dilated cardiomyopathy have had it paid for. I've never so far, we've run this for now 2-3 years, I had problems with payment situation.
And then what happens if they're approved to have a genetic abnormality? Okay, they come in with a cardiomyopathy, which may have been covered by their insurance. Now they have a genetic abnormality that may affect family members. How does insurance and everything deal with that?
Right. So one of the fears of family members is I'm going to be labeled with propensity to develop disease, and so that may affect my insurance eligibility. So there's a law that's been published, that's been passed in the US. It's GINA. So you are not allowed, insurance companies are not allowed to discriminate against genetic heredity for family members, but it can affect eligibility for life insurance and disability insurance. So that is a problem. And I think that partially also impedes genetic testing in family members. But if family members don't want to go to the genetic testing route, then we can use, echocardiography, ECG, and hopefully now AI-based ECG, which will tell us if the patient has low heart function.
Just to add, in Canada, we have the Genetic Non-Discrimination Act, which is analogous. So it's been passed since 2017 to offer similar protection for employment, insurance, et cetera.
Thinking about ethnically divergent populations and the fact that a lot of the data we have is from Caucasian populations, do you do a lot of whole genome sequencing when you have these unclear cardiomyopathies in ethnically divergent populations? And I'm just wondering, I'm thinking actually of a few patients we have now, someone who looks like they have tropical endomyocardial fibrosis from North Africa, an Iranian with a really thick heart, with a restrictive cardiomyopathy, but genetically negative for HCM HCM genes. And so I'm just wondering what your approach is to those ethnically divergent populations that have not really been studied in the same way.
Yeah, it's a very important point. And I think NIH in the US recognizes it's a huge, like that genetic variation study I showed. It's all, you're not supposed to take Caucasian as white population. And so I do think that we should embark on gene discovery, for patients with cardiomyopathy. You can start off with a regular gene panel, but if it's negative, not necessarily stop there. The question is who's going to pay for that? Do whole exome sequencing for these patients, right? The low-hanging fruit would be, say, someone from Iran who has a hypertrophic cardiomyopathy, but they have a family history, and then it's easier to identify a culprit gene when you have a trio, like father, mother, son, for example. So I would encourage that, truthfully. And if there's a large enough population, maybe you can get funding to do this because there's a big need for it. Especially the ones with family history, because I think the yield would be higher. Because, even with HCM, the yield is, they are 60%. We've done whole exome sequencing in HCM patients, and there's still 60% who just have no genetic identifiable cause. And we were discussing yesterday at dinner the dark genome, like that lady I showed you, the mucopolysaccharidosis. Why is she behaving like a homozygote? Well, it turns out that the other allele is a promoter variant that decreases expression of the gene. I didn't show you all that data, but that's why she had a functional, non-functional allele. So I think that's an important question. I think we should have low threshold to do discovery in those patients. A lot of the genes discovered are in the white population. Now, there is a program called All of Us. One of the problems with UK Biobank is the underrepresented minorities are really underrepresented in UK Biobank too, which is a big genetic repository. But All of Us has a large African-American Hispanic population. So hopefully, as we start leveraging that data, we will find genes that are associated, because there are 1 million people in All of Us. So hopefully you'll be able to find, genes that cause cardiomyopathy in those populations. Could be different, yeah.
I just want, so someone online, I think. So Christian, I saw your hand go up. Did you have a question?
Yeah, thanks. Thanks. That was a wonderful talk. I do have a question about inflammatory cardiomyopathies. These sarcoid patients, they're challenging, and I find there is a knee-jerk reaction just to say it's sarcoid, even in the patients where it's only the heart that's inflamed. And that to me is a bit of a red flag. And I'm just wondering, you mentioned it, but at the Mayo, when you have these inflammatory cardiomyopathies, are you treating them just with GDMT? And I understand there's no evidence and we don't know, or are you trialing immunosuppression?
Well, there's divergence in opinion about it. And so these are patients with non-invasive testing suggesting inflammation. You do genetic testing, they're gene positive. Immunosuppression is a lifetime commitment in these patients. And people feel nervous sometimes weaning immunosuppression because of risk of arrhythmias or progression of disease. Especially the genetic cardiomyopathy, I think it would be a lifetime commitment, right? Because with sarcoid, you have these ups and downs with inflammation, and you could possibly think of weaning. But if you're an immunosuppressive genetic cardiomyopathy patient, that inflammation set off because of the underlying genetic abnormality that's causing inflammation. So to embark on a journey of lifetime immunosuppression in a genetic inflammatory cardiomyopathy with all its attending risk, without knowing its therapeutic efficacy, I think is a big open question. So to answer your question, there are some in our group who would and some who wouldn't. And I probably wouldn't, unless, and we talked about this, you do a biopsy and you show inflammation histopathologically, maybe I would, but that's a tough one. And it's going to be hard because, there's a small number of patients, to do a trial and show benefit is going to be difficult, I think. But certainly warrants a worldwide registry of some sort. So, where we do registry-based randomization, I think, and look for maybe surrogate markers of improvement, like inflammation, arrhythmia burden, death progression, etc. I think it really cries out for a registry-based trial.
Omi, we'll give you the last word there.
Incredible talk. Thank you. I just had a sort of practical question. We view a proband that hasn't been tested in a family that hasn't been screened as an emergency, right? They've got first-degree relatives at risk, but there seems to be a big inertia that families sometimes have to overcome to get tested. And you've talked a little bit about ways to mitigate against that with, ECG-based screening, a live core-based screening that's sort of non-threatening and helps them engage. But I'm just curious, at a program level, how do you empower patients to communicate with their family members? How do you support them in that and increase the uptake of predictive testing?
Yeah, so Hirschberger, published a paper in JAMA. It was NIH funded. Basically, they created a booklet with lot of comprehensive information about cardiomyopathy, the risk for family members, etc. And they randomized one group of cardiomyopathy patients to getting that booklet and giving it to their family members, and another group just telling their family members, here's a letter that describes what you have, pass it on to your family members so they can pass it on to their doctors. So that's kind of the archaic, process that we have encouraging family members. And it's a situation where sometimes a proband may not want to discuss their medical situation. And this is all proband driven. And as a provider, you're not allowed to approach the family members, right? Because you have to maintain confidentiality of the patient. You can't say, well, your uncle had, cardiomyopathy, right? So it's become a problem. There was a patient's family member who died from sudden death. They had hypertrophic cardiomyopathy. They refused to tell the family members. And the family member died of sudden cardiac death. So it's a tough nut to crack. But I do think that offering at-home testing, so people are worried about getting genetic testing because it carries a problem regarding getting life insurance, disability insurance, etc., or they just don't want to live with the overhang of this, I am G positive, what's going to happen to me 10 years from now. To have this, so as you pointed out, we have the LifeCore device, send it to the person's home, and it's cheap and it's mobile, and from their home they can put two fingers, get an ECG, upload to the cloud, interpret by AI, and send a result to them. Your heart's okay. There's a very high negative predictive value. That could be reassuring potentially compared to the other interventions we are proposing. And I think it's going to take interventions like this. Just like Amazon.com made it convenient, right, for us to do shopping. And it can be done recurrently. Echoes, it's going to be expensive to say, do it every year and then every 2 or 3 years. And here, this is economically done. It's a 6-lead ECG from home. So you can do it every 6 months to reassure yourself, if you want to. So I think that's really the way of the future to try and reduce barriers from a systemic perspective. But cardiology, we always have to do clinical trials to show that it works. So we're in the midst of doing that, actually.
Well, I think we're past the top of the hour, so we will close out. Thank you so much for that great talk. And I look forward to speaking to you later.
Thank you.
Thank you, everyone.